This presentation provides an overview of the national culturally and linguistically appropriate standards in health and healthcare, commonly referred to as the class standards. For our purposes, we'll use examples related to behavioral health service delivery when discussing how to implement the class standards. And before diving into the standards themselves, we'll look at some of the challenges that led to their development and close with some of the benefits. As we all know, the United States continues to experience ever more cultural diversity in the composition of its national population. Following social movements that called for greater civic inclusion of racial and ethnic groups overall, health practitioners and social scientists in the 70s and 80s began highlighting persistent and troubling disparities in health status and access in these racial and ethnic populations as compared to the white population. It's important to note here that these health disparities, that is, the fact that some groups have poorer health outcomes and more negative experiences when they seek health care and needed services, have been recognized, acknowledged, and documented for decades, if not a century. However, a growing body of research shows that these disparities arise from inequality or inequities that are rooted in the distribution of access to political resources, social status, and power. This is the very essence of what we mean to a large extent when we discuss the social determinants of health. One of the key strategies recommended for improving access to behavioral health services then is cultural and linguistic competence, based on a growing recognition on the part of researchers and policymakers that changes in the nation's cultural diversity must be considered when designing and implementing behavioral health services. Before we jump into the concept of cultural competence, it's important to note that culture is widely accepted as influencing the experience, expression, course, and outcome of mental health and illness, help-seeking behaviors, and individual and community responses to interventions and programs. Culture is a complex concept, partly because it's defined differently by nearly every discipline that uses it. One of the key things to remember about culture is that it operates among social groups. It's often used interchangeably with identity, but it encompasses much more. For our purposes, we'll define culture as a set of beliefs, norms, and values shared by a social group, which shape their practices, decision-making, and behaviors, and which are taught and learned. Culture isn't static, it's dynamic, and so it changes with history and with technological innovation, for instance. We can see how culture operates in spaces where we address mental health and well-being in this country by looking at the clinical encounter. The clinical encounter is shaped by differences between patient and clinician in social position and power, for instance, and these are often associated with differences in cultural knowledge. But oftentimes they also reflect other cultural differences in areas such as identity, language, or religion, for example. In some cases, these encounters can be difficult to navigate for both parties because of differences in definitions about particular symptoms, what these symptoms mean, and how best to treat them. Although the concept of cultural competence and its importance for behavioral health service delivery as a means to address disparities was introduced in 1989, a number of researchers have noted more recently that the concept remains unclear with regard to how to actually implement it at the organizational and systems levels. In addition, in practice, cultural competence has often been focused at the individual level, such as the clinical encounter that we mentioned in the previous slide. Finally, in many cases, efforts to increase cultural competence have focused solely on the training of providers and clinicians, and these trainings have often centered on sharing knowledge about traits and characteristics about particular cultural groups, which can often veer close to stereotyping the very groups we're seeking to improve service delivery to. The development of the national class standards can be seen as part of a larger national call to action to address disparities that are experienced by culturally diverse groups in this country. This timeline highlights some of the federal laws and policies that were enacted in the latter half of the 20th century. It also highlights some more recent federal documents that support this ongoing call to action. When you look at this timeline, the national class standards are placed in a particular context. They can be seen as an outgrowth of the historic passage of Title VI of the Civil Rights Act law, which prohibits discrimination on the basis of race, color, and national origin on the part of programs and activities that receive federal financial assistance. So they're very closely linked to this and other laws and policies shown on this timeline that have focused on increasing access to needed services and inclusion for all Americans in all aspects of our society, regardless of cultural identity or affiliation. The original national standards for culturally and linguistically appropriate services in health and healthcare were developed and published in 2000 by the U.S. Department of Health and Human Services, Office of Minority Health. The key premise and expected outcomes underlying the standards are advancing health equity, improving quality of services, and supporting elimination of health disparities. The National Class Standard serves as a blueprint for sustaining culturally and linguistically appropriate practice and policies in health and healthcare. The standards were updated in 2013, and enhancements introduced to them include an expanded definition of culture that goes beyond race and ethnicity to include geographic location, sexual orientation, gender identity, socioeconomic status, and a broader definition of health that includes social, spiritual, mental, and physical well-being. The principal standard, or Standard 1 of the National Class Standards, serves as the foundation for the rest of the standards, which provide guidance to organizations seeking to provide culturally and linguistically appropriate behavioral health services. It reads, to provide effective, equitable, understandable, and respectful quality care and services that are responsive to diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. The components of culturally and linguistically appropriate care shown on this slide are taken directly from key documents and research used to update the class standards in 2013 and further support the work of behavioral health practitioners who are focused on improving behavioral health services for the populations they serve. Effective care and services are those that successfully restore an individual to her or his desired health status and help to protect her or his future health. Vital to the provision of effective health care and services is the fact that providers must accurately understand the issue or illness, determine a course of treatment or services for that individual, and negotiate the solution or treatment successfully with that individual. That is followed by equitable care and services, which must apply to all individuals and groups regardless of their cultural identities. The aim of equitable care and services is to reduce the burden of illness, injury, and disability, and to improve the health and functioning of all people in the United States. As part of this charge, it's important to foster an environment in which individuals from diverse backgrounds will feel comfortable discussing their needs with any member of an organization's staff. Further, the Health and Human Services Consumer Bill of Rights states that all recipients of health services have the right to considerate, respectful care from all members of the healthcare system at all times and under all circumstances. Accordingly, all members of the health and healthcare team serving a particular individual, regardless of cultural identity, should provide individuals with assurances that disrespect or discrimination of any kind is intolerable, and provide individuals with reasonable assistance to overcome language, cultural, physical, or communication barriers to services and treatments. Finally, services, interventions, and programs should be understandable to the people being referred to and experiencing these services firsthand. This refers to language, but also to cultural beliefs and practices that social groups use to cope with illnesses and disorders, and which shape beliefs about what it means to be healthy and well. In addition, it's recommended that providers give individuals some help with understanding the systems and services they need to navigate in order to successfully complete them. The remaining 14 standards are organized by the following themes: governance, leadership, and workforce development, which encompasses standards 2 through 4, communication and language assistance, which includes standards 5 through 8, and continuous quality improvement and accountability, which includes standards 9 through 15. In general, the 15 national class standards are considered to be equally important as guidelines to behavioral health organizations for advancing health equity, improving the quality of services, and eliminating disparities. The first theme of the standards includes governance, leadership, and workforce development. Governance refers to the oversight that a behavioral health organization provides in terms of policies, structures, and processes. These set the stage for the way in which agencies, organizations, and their staff members at all levels work. With regard to the class standards, organizations should be able to say whether the provision of culturally and linguistically appropriate service delivery are included in the mission and vision statements, stated core values, and even in their strategic planning documents. Organizational leaders are critical to communicating the importance of ensuring that stated policies and procedures are put into practice. Does your organization's leadership support the values of class? Is this support communicated at all levels of the organization so that all staff members serving the public reflect a commitment to providing effective, equitable, respectful, and understandable care? Finally, does your agency or organization make an effort to hire staff from diverse backgrounds that reflect the cultural identities and languages of the populations of focus that you serve regularly? In addition, are staff trained regularly to ensure that they are aware of the latest and most effective service delivery practice for diverse groups and communities? A key point to consider when responding to these questions is the vital importance that leadership plays. For instance, this commitment to workforce and professional development in particular requires budget considerations and a mandate from leadership for other staff to ensure that these practices are taking place. Theme 2 of the class standards focuses on communication, language assistance, and health literacy. These standards in particular are viewed as mandates for organizations receiving federal funds. Under Title VI of the Civil Rights Act of 1964, as implemented by Executive Order 13166, these organizations must take reasonable steps to provide meaningful access to their programs for individuals with limited English proficiency. In order to meet the guidelines of class standards 5 through 8, behavioral health organizations should offer language assistance to anyone with limited English proficiency or another communication need. These services should be made available at no cost to those seeking needed services and care. In addition, they should inform everyone of the availability of language assistance services, verbally and in writing, that is clear and in the preferred language of individuals that rely on this organization for care. They should also ensure that persons providing language assistance services are well trained in that role and avoid the use of untrained individuals or children as interpreters. Finally, they should provide easy-to-understand materials and signage, whether in print or other media, in the languages commonly used by the organization's population of focus. Theme 3, Engagement, Continuous Improvement, and Accountability, emphasizes the importance of maintaining organizational responsibility for ensuring that culturally and linguistically appropriate service delivery is supported at all levels of an agency or behavioral health organization. As you see on this slide, these standards emphasize the establishment of clear and consistent policies and practices for organizational accountability in the area of culturally and linguistically appropriate service delivery. While Standards 9 and 14 are focused on the establishing of such policies, Standards 10, 11, and 12 promote the use of regular assessment and data collection both internally and externally. Standard 10 recommends regular assessment of an organization's service delivery practices to track how well they do with regard to class. Standards 11 and 12 recommend regular data collection on demographic data for the diverse populations served by an agency and regular updates on existing community needs and assets that these populations of focus rely on. Theme 13 recommends building partnership with service users and other community members to design, implement, and evaluate policies, practices, and services to ensure cultural and linguistic appropriateness. Finally, Standard 15 recommends that organizations establish a process for communicating a behavioral health organization's progress in implementing and sustaining culturally and linguistically appropriate service delivery. There are a number of ethical and practical reasons why providing culturally and linguistically appropriate services in health and healthcare, including behavioral health, is necessary. The first is quite practical. It's to respond to the current and projected demographic changes in this country, which we expect to continue in the coming decades. The class standards also support the elimination of long-standing disparities in the health status of culturally diverse individuals and populations. This includes improving service user satisfaction in services and healthcare delivery, access to needed services, and ultimately improving behavioral health outcomes. Meeting the class guidelines can help behavioral health organizations improve the quality of services and overall health outcomes. This includes supporting increased staff competence and confidence in providing effective and quality services for all, and increasing understanding of the ways in which culture interacts with behavioral health. Finally, they also help organizations meet legislative, regulatory, and accreditation mandates, gain a competitive edge in funding and recognition, and reduce costs by decreasing the likelihood of liability and malpractice claims. To download a copy of the National Class Standards, visit the Think Cultural Health website established by the Office of Minority Health using the following link. Thank you.